too old for these lights.
We're just waiting for people online, so Bobby's going to come and confirm. Good evening, everyone. A very warm welcome to everyone attending online and everyone here. Thank you for coming. Women in Mind events have been held for the past 7 years by the Women and Mental Health Special Interest Group at the college in collaboration with Diversity and Inclusion team at IoPPN, King's College London. It's our great pleasure to hold this event at the college for the first time. Just a bit of quick housekeeping before we begin. So there are no fire alarms. You know what to do if it sounds. Please do not leave any valuables unattended at any time. And these are only for people who are attending here. Obviously, those online, you're free. Please set mobile phones to silent. There will be a Q&A at the end of those in the room. We're very sorry we can't facilitate that for those online, but thank you for sending questions for those who have. The event is being live streamed and it's also being recorded. For those of you who are active on social media, please use our hashtag WIM2023. So WIM for Women in Mind 2023. Now that's done, it's time to focus on this evening that creatively looks at the painful reality of racism. I'd like to begin this evening with a poem. Between us is color, raw, painful, yet in denial, eroding fragile trust. Blind to color, you chant sameness, 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 bouncing off thick walls of prejudice, deafening silence. Blind to the color of my skin, color of my pain, for my blood is still red. I'm ugly. I'm beautiful. I'm colorless. I'm colorful. I bleed. I starve. I'm left to die in anger, in hunger. In my color, I stand strong. I stand tall. I stand weak. I stand broken to find my strength, my space, my voice. In your color, you stand strong, you stand tall, you stand weak, you stand broken to find your strength, your space, your voice. We're here today as a collective. How do we begin to see structural racism? How do we stop being in denial? It is my great pleasure to invite Dr. Stella Kingett, who's the chair of Women in Mental Health Special Interest Group, to please come and introduce our guests this evening. Thank you.
Welcome everybody from me as well, and thank you so much, Raka, and that was a beautiful poem. And I'd like to take a moment actually to say a big thank you to Raka for all her work to organise this important and interesting discussion this evening. It is my very great pleasure as chair of the Women's Special Interest Group to introduce our two speakers for this Women in Mind event about confronting racism denial. It is a real honour to be able to hear from you both this evening. Our host for this evening's conversation is our own President-elect of the Royal College of Psychiatry, Dr. Lade Smith, CBE. And Lade will be the college's first black president and the fifth woman at the helm. Lade is Clinical Director of Forensic Services at the South London and Maudsley NHS Foundation Trust. She is a visiting senior lecturer at King's College London. Together with Dr. Rajesh Moran, Lade is Joint Presidential Lead for Race and Equality. She is also Clinical and Strategic Director of the college's National Collaborating Centre for Mental Health. Lade has vowed to nurture and support psychiatrists so we can retain and strengthen our workforce and to address the treatment gap and fight for resources to deliver therapeutic care. And she has also said she will ensure fairness for all and tackle inequality for patients and for staff. And our esteemed guest for this evening's conversation is Professor Camara Phyllis Jones, MD, MPH, PhD. She is currently a Leverhulme Visiting Professor in Global Health and Social Medicine at King's College London. Her work focuses on naming, measuring, and addressing the impacts of racism on the health and well-being of the United States and the world. She is well known for her allegories on race and racism, and I'm hoping we may get to hear some of these this evening. These illuminate topics that are otherwise difficult for many to understand or discuss. And in the words of Professor Jones, that racism exists, racism is a system. Racism saps the strength of the whole of society, but we can act to dismantle racism. Professor Jones is a past president of the American Public Health Association, a commissioner on the recently launched O'Neill Lancet Commission on Racism, Structural Discrimination and Global Health, an elected member of the National Academy of Medicine and the American Academy of Arts and Sciences, and an honorary member of the Royal Society for Public Health. Thank you both so much for speaking to us this evening and sharing your expertise. And I will hand over to Dr. Lade.
Okay, so ever the opportunist, I'm going to take this time that we have your rapt attention to introduce some work that we're doing, because we started to realise at the college, and I have to say, it wasn't me who did this. This is our current president, Adrian James, and our CEO, Paul Rees. A few years ago, they said, we need to try and do something about racism. What can we do as a college? Because frankly, racism is a problem for mental health care. Even people who may not realise it, we have to accept that. And in fact, at that time, and a lot's happened in 3 years, this was pre-George Floyd, this was pre-COVID, and at that time, people were kind of like, don't talk about racism, it's not really important, it's not that important anyway, it's just some people who are a few bad eggs. And actually, they said, that's not quite right. Myself and Raj said, well, it'd be quite nice if we could have some guidance. And actually, Paul and Adrian said, yeah, actually, let's do something about tackling racism in the workplace, because we know that it's really bad for our staff, particularly psychiatrists, and we know that it is something that has a negative effect on patient care. And we have a fantastic communications team, our comms team, and what the comms team have done is they've supported us. Where's Ruth? Ruth Adams, Corinne sitting next to her, and they supported us in developing some guidance that we think is going to be useful for workplaces. And not the usual get your EDI person to do something about it. This is something that's going to be very practical. And there are a few people in the room who've supported this. Amrit Sakar, Chinwe Abinwa, on her phone doing Twitter, I hope. Claire, where's Claire? And what this is about really, it's coming soon. We're launching on the 26th of June. I wanted to let you know about it so you're a bit aware about what's coming. But it's because the evidence shows that racism is a problem in organisations across the, who employ psychiatrists across the UK. All the surveys have said so. And it's 60% of psychiatrists from a minoritized ethnic background have experienced racism in the workplace. And there are thousands of staff across the NHS have also complained about the same. And the BMA, even the GMC, have said this is a big problem for our staff, actually. At a time when we have significant workforce shortages, and particularly when it comes to doctors. Doctors, we're portable. We can go and work in other places in the world. And what we need to be able to do is to hold on to our doctors, particularly our psychiatrists. And that's why, even if you're not that worried about racism, understand that this is the kind of thing that drives people away. We decided we just don't want to tolerate this anymore. And the evidence is clear that the recommendations that we've had so far haven't been enough. We need actions now. And this guidance is about actions, and it's to support employers and employees to know what to do should they encounter racism. And this is on an individual level, interpersonal level, but also, as I hope we'll hear from Camara, about the institutional and structural factors that can drive people away from being able to do their best at work. And it's really what we're doing is we're calling on leadership in all employer organisations to adopt this guidance. The guidance provides the evidence base around racism, the legal obligations, case studies, resources, it's information about allyship, what to do if you're a bystander and you see something happening. There's a maturity matrix, which is essentially a way of benchmarking yourself as an organisation and seeing what you need to do. And then there are 15 transformational actions with examples of how organisations can actually improve. And that includes the 6 domains: leadership and strategy, accountability, equity of opportunity, organisational culture, thinking about specific sections of the workforce, our SAS doctors, our specialty doctors, and our doctors who are internationally trained, international medical graduates, and then thinking about addressing their concerns. And what we hope is that this will help organisations to tackle things at a strategic level, a systemic level in their organisation. And from the 26th of June, we are launching this guidance. So this is just a call to you to watch out for it. And also, very importantly, you're all here supporting this event. We want you to be able to support this guidance, to help it embed it into practice. And that's why we're mentioning it today. And I can't finish this without mentioning Adrian, because it was before Adrian became president, that's Adrian James, our current president, who's demitting in July. Before he became president, he said this: racism causes pain, which can contribute to mental illness. As psychiatrists, we must combat systemic racism within services and the profession. And I agree. Anyway, so I thank you. And now we will talk to the main person, Camara.
Thank you.
Okay, so I'll tell you now, I was absolutely delighted when Camara agreed to do this, okay? And Camara is, when I heard that Camara had come to Britain, because Camara usually lives in America, and when I heard she'd come to Britain, and that not only had she come to Britain, she was actually at King's, I have to go and see this woman. I went to hear Camara speak, and I've read her work, I've followed her work for years, but I was transfixed. And I was transfixed, and you'll understand why. What we're going to do today is I'm going to ask Camara a question, and I might get another question in, but I'm hoping that Camara will do what she normally does, which is to enlighten us and help us to understand the thing that's most important to us today. And this is the question, actually, Camara. Why is racism important to our health?
Why is it important to our health? So I will take it from a few angles. The first is, why should we as healthcare providers be interested in racism? And then I'd like to talk about, this is the outline of what I'm thinking right now in response to your question, Lade. I'd like to start there, but then I want to make sure that we talk about the importance of racism denial and how you all as a Royal College of Psychiatrists are already manifesting a push against racism denial by saying the word. I do want to share with you a few allegories, but let me stand up. There's a thing that I do. So if you don't mind us being in conversation, but also I share some slides. I have like a backup deck of slides. And what I want to show you right now are the slides that I use when I'm trying to talk to healthcare providers about why they should care about racism. Like, why are you guys here? You know, what is this about? I'm a psychiatrist, and I try to do, or I'm a therapist or whatever, and I'm doing the best that I can. Why is racism even there? Because we need to understand that first before we can move on. So, what I share with people, and I don't know if you saw this or not, is I call this my cliff analogy. Yeah. It helps us to understand 3 different dimensions of health intervention. I'm going to run through it so quickly because I don't want to use up a lot of the time, so hold on. But here we go. Whoops! Boom! Somebody has fallen off of the cliff of good health. Physical health, mental health. It could be the cliff of housing. It could be the cliff of education. They have fallen off a life cliff, right? And if that were you or somebody in your family, you would be delighted to find an ambulance at the bottom of the cliff to speed you on to care. But if we were concerned about other people who might come along that cliff face, so if we were concerned about public health, community health, population health, we might well ask ourselves, what else could we put in place as a health intervention besides just stationing lots of ambulances at the bottom of the cliff? So somebody in the room is going to say, I know, let's put a net halfway down. That way, if people fall, at least we can catch them before they get crunched up at the bottom. That's a great idea, although nets have holes in them. Somebody might fall through the cracks, right? And we see that a lot. But never mind, let's make that a trampoline halfway down. No holes in a trampoline. But even if we have a trampoline halfway down that cliff, we might well find ourselves with lots of people just bouncing up and down at half functionality, not able to get back to the top of the cliff. So what else could we put in place as a health intervention? Well, clearly we need to be thinking about a fence at the edge of the cliff to keep people from falling in the first place, right? But even that fence has to be a very, very strong fence if there's a lot of population pressure against it. So what else can we do as a health intervention? Well, we can move the population away from the edge of the cliff. So I'm going to pause right now and say, let me label the interventions that I've depicted so far, where the ambulance represents acute medical care, and what we on the public health side of the house describe as tertiary prevention, preventing complications from disease that's already manifest. The net or trampoline represents our safety net programs, as well as early detection, screening, secondary prevention. Fence represents primary prevention, keeping bad things from happening in the first place. Moving the population is addressing the social determinants of health. So that includes those social determinants of health. I don't know how much you guys are using that over here in terms of, right? But so those are the determinants of health and illness that are outside of the individual. They're beyond our individual genes. They're beyond our individual behaviors. They're the context of our lives, so they include individual contexts like education, occupation, income, wealth. So addressing social class, addressing poverty is an important way of moving the population away from the edge of the cliff. Also includes neighborhood contexts like the availability of excellent foods or, clean water, clean air, jobs, all of that kind of thing. So addressing adverse neighborhood conditions. So that's all good, right? And we can see already that this cliff, by helping us understand different levels of health intervention, could be useful for starting a conversation with a community. How should we, in our mental health resources, how much should be in ambulances versus nets versus fences versus moving the population? We could go to the NHS and say, we have an opinion about this. You could go to Parliament, right? But as useful as this diagram is so far, it has a huge fatal flaw. And the huge fatal flaw is that it does not yet equip us to understand how disparities in health outcomes arise. Why do we have, I don't know, is it 5 times as many black men, sectioned into mental health services? Why is it even when they're in the mental health services, they're not getting the top care? What are these disparities about? So, as I've presented this cliff so far, insufficient. So let me ask you to hold the cliff in the back of your mind. I'm going to talk about how health disparities arise on 3 levels within the US context. You guys have some of all of this here too, although the proportions are different. And then we're going to go back to the cliff, right? And answer the question, why should we be thinking about racism? In the US, we have lots of evidence about differences in the quality of care received within the healthcare system. We had an unequal treatment report by the National Academy of Medicine. At that time, it was the Institute of Medicine, 2002. That's now 21 years ago. That sent shockwaves when they documented differences in how vigorously a person's chest pain might be investigated or treated within the same hospital system or covered by the same insurance, depending on their race or ethnicity. Differences in how much pain medication somebody going into A&E, into an emergency department, might get, depending on their race or their ethnicity. So that was the first thing, but even the people who wrote that report were like, we know that this is not the end-all and be-all of how health disparities arise, because in the US, more so than in the UK, but I think there's a little bit of this here too, there are differences in access to healthcare in the first place, right? So you have differences in quality care, you have differences in access to care, but I'm hoping that everybody in this room recognizes that health is not created within the health sector. So there's a third level at which health disparities arise, which are differences in the conditions of our lives, differences in our life opportunities, exposures, resources, and risks that make some people and communities sicker than others in the first place. 3 levels at which health disparities arise: differences in quality of care, differences in access to care, differences in underlying exposures and opportunities. You could draw it as a pyramid, in that order, or even understand it better as an iceberg where the huge hidden base are the differences in the conditions of our lives. Then in the US especially, but here to some extent, the same people who've been made sicker are having more troubles accessing healthcare systems. And then even the lucky ones, sometimes who get into the healthcare system, especially in the US, are further injured because of differences in quality of care. Keep that in the back of your mind, because now we're going back to the cliff. I hope this is interesting to you guys. You're like quizzical, like, what is she talking about? She asked about racism, right? Okay, so hold on, we're about to get there. Going back to this cliff, now we have to recognize that we are not dealing with a flat, 2-dimensional cliff, but actually we are dealing with a 3-dimensional cliff. And at some parts of the cliff, there might be an ambulance there, but maybe that ambulance has a flat tire, so it's slow or goes off in the wrong direction. Or maybe there's no ambulance there, nor net, nor fence, and usually at those parts of the cliff, the population is being pushed closer to the edge. So now let me label these observations about the 3-dimensional cliff with how health disparities arise, where differences in quality of care are represented when there's an ambulance there, but it's slow or goes off in the wrong direction. Differences in access to care are no ambulance, no net, no fence. Differences in underlying exposures and opportunities are represented by the closer proximity of that greeny population to the edge. So now we need to ask ourselves, why? There's a bunch of questions we need to ask. The first is, why is the cliff 3-dimensional? And that is usually because of historical injustices that are perpetuated by present-day contemporary structural factors. But given that the cliff is 3-dimensional, we also need to ask, why are there differences in how resources are distributed along this cliff? And why are there differences in who's found at different parts of the cliff? Why are the oranges backing away and the greenies being pushed closer to the edge? And when we start asking and addressing these questions, we are doing something that's different from addressing the social determinants of health, including addressing poverty or adverse neighborhood conditions. Now we are doing what I describe as addressing the social determinants of equity or inequity, which are systems of power that can differentially distribute resources and populations and include racism, sexism, heterosexism, and these other systems of structured inequity. So I am going to stop there to say, often I ask, well, let me just say 3 dimensions of health intervention I have. Health services along the edge of the cliff, along a line. You think about 1 dimension, that's a line. The ambulance, net fence, these are our health services. In the US, we're trying to get to what you guys used to have and still have, but it's being eroded over 13 years of disinvestment. But that is a national health service, right? So in the US, we don't have a national anything, right? Okay, but even if we got there, and as you can see here, even if we got there and we had universal access to high-quality health care, right? You can, which is what we aspire to join the rest of the world. That's how a civilized society values all of its people equally. But even if we got there, you can overwhelm any system if people are pushed up against the edge. So we must move into that 2nd dimension, which we can display on a flat plane. We must address the social determinants of health, including poverty, adverse neighborhood conditions, and the like. We must move the population away from the edge of the cliff. But if we do that without recognizing that we're really dealing with a 3-dimensional cliff, we're at risk of moving some of the population, but not all of the population, and actually making health disparities worse. So we must acknowledge and address the 3-dimensionality of the cliff and address these social determinants of equity or inequity, especially racism, because there's so much racism denial that we must highlight that, especially racism and these other systems of structured inequity, if we're going to achieve social justice and eliminate health disparities, disparities in care, disparities in what's happening to our carers, all of that. So this is my quick answer, Lade, to to what, and you know, I could go on more and more, but I'm not going to. But hold on, close your eyes, people who are looking at these slides, because I do want to set myself up for something later that we may or may not address, but I'll just put it there. So anyway, so why am I here at the Royal College of Psychiatrists talking about racism? It's because even if you are trying to be the best ambulance driver that you can be, right? And you're training others to be the best ambulance driver that you can be. Or maybe you're trying to be a net, right? Or a trampoline. Maybe you're trying to be a fence. But wherever you are in your work thing, first of all, you should realize you are part of a big system, right? And especially you guys are more part of a system than what we have over on my side of the Atlantic. You're part of a system, and even if you're trying to be the best ambulance driver you can be, you need to wonder, is there a net above me? How strong is the net, right? Is there a fence? How strong is the fence? How close is the population to the edge, right? At what part of the cliff am I operating? And do I even do things the same way when I'm working at different parts of the cliff? That's in your day job. We have to, wherever we are, we need to understand where we are in all of these things. But all of us, as people who are concerned about the whole, as citizens, not national citizens, but as people who are concerned about the whole, after we clock out of our day job, all of us, I would say, first need to be concerned about the three-dimensionality of the cliff and the maldistribution of resources and people along that three-dimensional cliff. So we all need to be concerned with racism, especially because there's so much racism denial, even if in our day job, so both and, because the racism is structuring and perpetuating this three-dimensional cliff. It is the root of the maldistribution, and I'm not talking yet about within the workplace. I mean, this is just in general, but in big and small, you know, what is that called? Where, you know, like, you know, if you look at a coastline, it looks a certain way, and then you look closer, it looks something.
In relief.
Huh?
When you look at it in relief.
Well, it's something, I don't know, that's not the word I had, but anyway, things at different levels, right, that look the same at different levels. You can be very close to fractals. Okay. Fractals, that's what it is, fractals. So that's what we're dealing with. So the thing that's affecting the whole society is affecting workplaces, it's affecting, you know, in communities. So racism exists. You know, may I say another thing before you jump in?
Sure.
Yes.
No, please do.
No. Usually, if I'm talking to a group of people, and they're like, why is she here? Then I sort of start with that cliff. Because, and I sometimes joke and I say, I've said the word racism 2 or 3 times now, and nobody fell off their chair. And then, so now let's go into a deeper conversation. So that's what I'm about to do, right? So I've said that we as a profession, I'm a physician, epidemiologist, right? We as people need to be naming racism. But as president of the American Public Health Association, when I launched a national campaign against racism, also before the onset of COVID, before the murder, gruesome murder of Mr. George Floyd, and so many before him and so many after, before all of that, so in 2016, that wasn't just a walk in the park. Some of you might think, oh, you live in the United States. Of course, you could launch a national campaign against racism. You know, you guys have a big problem over there. That's what a lot of you guys think. There's a big problem over there in the US. Yeah, there is. There's a big problem over here too, right? People, if you ask white people in the US, is there a problem with racism? Most of them would say no, right? So there's a big problem all over the world. But when I launched it, there were 3 tasks for this national campaign against racism. The first was to name racism. Why? I mean, when I say name racism, I mean say the whole word. Don't stop at race or equality, equity, diversity, inclusion, disparities, disproportionalities. You know, those are all good. But say the whole word, racism, because we must name a problem in order to get started on the solution. That's step 1. But as necessary as it is to name racism, we have to go beyond that and move to action. So the second of the 3 tasks was to ask the question, how is racism operating here? In my workplace, at my child's school, in the college, in London, in the UK, how, in my community, in my religious institution, how is racism operating here? And so I'd love to talk to you about how do you approach that question. But why do you ask that question? Because what you're trying to do is landscape and identify some early promising levers for intervention, targets for action that are within your wheelhouse. So we can't all, and that's what you're doing right now in this plan that you're about to launch on June 26th.
Yeah.
So impressed. So what you're trying to do is you're saying, how is racism operating here? And then once you identify some promising targets for action, then you need to organize and strategize to act. Now, we all have power. Yes, we do as individuals. We have power to put things on agendas. We have powers, to start efforts, to sponsor a talk, and we have powers to hire students. We have power to speak to our patients and be miraculous, right? We have power to do a lot of things as individuals. But the real power is in collective action. So we need to understand and use the tools in our little space, in our wheelhouse, but then we need to organize and strategize to act. So that's the third of the 3 tasks of the National Campaign Against Racism. Organize and strategize to act because collective action informs us. None of us knows it all. It inspires us, it propels us, and it protects us. Does a lot of other things too, but collective action is underappreciated, especially in a society like ours, which is so narrowly focused on the individual. We even lose we think about our individual efficacy. We lose the idea of collective efficacy. We also lose the idea that structures are important and all that. So I'll say one more thing and then I'll let you get a word in edgewise. But if the 3 tasks of my national campaign against racism, which I now recognize to be the 3 steps of anti-racism as a process. So anti-racism is not a program, it's not a, we did that, it's a process, right? The 3 steps, name racism, ask how is racism operating here, organize and strategize to act. Those 3 steps, once you get through one time, you need to iterate. It's looping, so you need to name racism again and still, because people will say, oh, I thought we did that. That's so 2020, what are you talking about, right? So then you need to ask, how is racism operating here? Again, still, hopefully you have developed a larger mass. We're working toward critical mass in our collective action. But so you might have a bigger, set of tools to work with, or targets that you can do. But also you need to ask because people might have come behind you and undone the work that you did. And part of anti-racism is anticipating and preparing for pushback. I say that in the United States, we should never have been surprised that after an Obama presidency, there was a Trump presidency. That should not have taken us off guard. People were devastated, crying. We had no idea, right? And then the third step, then you need to continue to organize and strategize to act, which means, as amazing as the effort is that you're going to launch, it is step 1. It is step 1 because this is not a 3-year effort, a 5-year effort. The shortest it could be is a 20-year effort, but this is a multi-generational effort, which makes some people feel discouraged or tired. But our role right now, we are on this earth right now. So our role is to be part of this anti-racism process, of this effort, not thinking that we're going to see everything fixed with our eyes or even our children's eyes or our grandchildren's eyes. But know that if we don't start right now, then it puts it off by another generation because the systems and structures and policies, all of these things are deeply ingrained. The value system. I want to say 2 things, and then I'm going to let you. She said she was going to ask me one question, and then I was going to go. And I was like, no, Lade, we're going to have a conversation. But the 2 things. The first is, when you name racism, well, let me finish the other thing. If it's multi-generational, here's what we have to do. We have to reach up to those who've gone before us, who are still here on the planet, and ask them, what have you tried? What worked, what didn't? So we need to learn from our elders. We need to be about building a critical mass, and we need to be deliberate about reaching to the younger people so that they can teach us and they can learn from us. We need to be passing batons. I think about passing barrels of batons. Right? And everybody who gets one of my batons needs to create their own barrel of batons and pass that. Right? So this intergenerational thing, we don't need the young people thinking they're the first ones to be thinking about these issues. Right? They need to learn from us. We need to learn from them. This is ongoing work. But now I wanted to say, if naming racism is the first thing, there are 4 key messages when naming racism. It was in my introduction, but I'm going to say it again so everybody can like really lock in. The 4 key messages are: 1, racism exists. I say that because racism denial is so staunchly held in my country and in yours. There are people who do not understand that racism is foundational in the history and wealth of the United States, in the wealth and history of the United Kingdom. Foundational. And it can be so seductive. We could fall into what I describe as the somnolence of racism denial, even though we've been moved, people say the Black Lives Matter movement, or however you want to name it in different parts of the world. We've been moved for a time, but already I start seeing us falling back. Right? So racism exists. Racism denial is like a huge black hole in our national landscapes. Now, you know black holes up in the universe? I'm not an astronomer, but this I know about black holes in the universe. They are massive, they are powerful, they suck everything that comes near into it, and they're invisible. Why? Because even when light comes near, it gets sucked in, it can't get reflected off. That is how racism denial is operating in our societies. So the first key message when naming racism is that, yes, racism exists. If people ask you about that, ask them to read history. In our countries, we are ahistorical. I talked about the narrow focus on the individual. By the end of this talk, I'm going to talk about 7 barriers to achieving health equity. But another one is that we're ahistorical. We act as if the present, we're disconnected from the past. Lade, I know I'm talking to you, but I'm talking to them too. that we act as if the present, we're disconnected from the past, as if the current distribution of advantage and disadvantage were just a happenstance. So when people doubt, does racism exist, they haven't read history. All you have to do is read history. Actually, all you have to do is walk into the British Museum, right? All you have to do is go across town and stay a while, right? All you have to do is talk to strangers, right? All you have to do is stop trying to find alternate explanations for what we see in terms of the distribution of education and wealth and housing and that kind of thing, and stop putting it inside people and understand that structures exist. And, so that's the first, racism exists. The second is that racism is a system. When I say the word racism, after people have heard me for just a few minutes, they're not scared that I'm trying to peer deeply into their souls to say exactly how racist are you. I'm not talking about individuals. I'm talking about a system of power. The third is that racism saps the strength of the whole society. That's a very important message that many of us miss. The fourth is that, yes, we can act to dismantle racism. So I am not hopeless. If I were hopeless, I might as well, just stop breathing, right? My hope is in action. And in fact, I will say this. When you stop just talking about something and you start acting the way that you're encouraging the college to do, that action can be life-giving. It fills people, when you start acting, and especially when you start seeing small successes, or even start getting pushback, but you're in it with some other people, not just by yourself, so you don't feel overwhelmed, you feel instead motivated and all, it can be life-giving. So the moment that we go from naming racism necessary but insufficient and move to action, that is what's going to propel us. So that was the first thing. The second thing is my definition of racism, and then I'll ask you some questions, Lade. So you've heard different parts of the definition, but here it is in one sentence, and then I'll go and lift up 4 things. Racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. What are the 4 high points in that definition? First, that racism is a system. It's not an individual character flaw. It's not a personal moral failing. It's not even a psychiatric illness, as some people have suggested over the years. Although racism manifests in all of those ways, but in its essence, it's a system of power. So 1, racism is a system. A system of doing what? Of doing 2 things, structuring opportunity and assigning value. That's the second important thing. Based on what? On what basis is the opportunity structured? On what basis is the value assigned? Based on so-called race. Every time I say the word race, you see my fingers going in air quotes. When I write it, I put quotes around it because so many people are confused and think it's biology. It is not. Race is the social interpretation of how one looks in a race-conscious society. In most parts of the US, you look at me and I'm clearly black. In some parts of Brazil, you look at me, I'm just as clearly white. In South Africa, I've experienced all these places. In South Africa, you look at me, I'm just as clearly colored. Here I am, same physical appearance, but the social interpretation of my physical appearance in those 3 settings and in many others, right, has assigned me to different racial groups. If I were to stay in any of those settings long enough, then my health outcome, educational, all that stuff would take on that of the group to which I've been assigned, even though I would have the same genes, behaviors, all of that in all of these places. You guys are nodding because you're looking at me and I'm sort of like light skin, frizzy hair, whatever. What I'm saying is true for everybody in this room. There's some other place on this earth where your so-called race would be quite different from how you are living it today. In some places you would have no race. Race is not, it's not a race-conscious society. In others, you know. So what I'm saying is that race is the social interpretation of how one looks in a race-conscious society, and it is the substrate on which racism operates day to day and over the centuries to differentially structure opportunity and assign value. So that was the 3rd thing. System, 2 impacts based on race. The 4th important thing is that it has 3 impacts, racism does. When people finally recognize, oh, I guess racism does exist, which takes people along, they recognize that it unfairly disadvantages some. But it shouldn't take any of us long to recognize every unfair disadvantage has its reciprocal unfair advantage. So racism is also unfairly advantaging other individuals and communities. And I could go long on that, so you can ask me if you want, right, about why we don't talk about that. Well, I'll just say it makes some people uncomfortable, especially people who are living as white, uncomfortable. And when I see people get uncomfortable at that point, I used to almost apologize, say, oh, I'm not trying to make anybody uncomfortable. Shake it off. I'll tell you more stories, right? I don't do that anymore. I say, if you feel uncomfortable recognizing the reality of unearned white privilege, I want you to lean into that discomfort by reading more. Read history. Go across town and stay a while. Speak to strangers. I mean, there are many things you could do. Because, why do I say that they should not retract from the discomfort, but lean into the discomfort? Because for every single one of us, the edge of our comfort is our growing edge. Right? The 3rd impact, that racism saps the strength of the whole society, is the impact that we all need to lift up and understand most urgently today. We need more media stories about that, more data collection, more conversations at our boardroom tables, faculty tables, dinner tables, that racism is sapping the strength. So this is, again, where you're getting, is sapping the strength of the whole NHS, you know, it's sapping the strength of workplaces, it's sapping the strength of everything. So I will stop talking there and say, Lade, what that I've said has made you, what is the hardest thing for people to really understand or accept here? Or it may not be anything I said, but in your observations, what is the hardest barrier here?
I think, as you were speaking, I was thinking about psychiatry and mental health.
Yes.
And it's interesting that in medicine, psychiatry is set aside as the medical specialty in which there is racism. As though
Is it really?
Yes, very much so, actually. And it's often said that psychiatry is racist. In fact, so Suman Fernando, who's he's a psychiatrist who's written prolifically around this, he said that essentially psychiatry is institutionally racist. And actually, he's not wrong, but what he hasn't also said is that actually so is everything else.
Yes.
And it's funny because I was actually finding myself thinking, yeah, the issue is that for many, many years, and still, we think of racism as being that interpersonal stuff.
Right.
And so the very worst thing you can say to somebody these days is that they are a racist or they're a paedophile, or that they're a racist paedophile. You know, that's it. That's the worst thing you can say. And literally, so as soon as people hear that word, it is like a barb, actually. What, are you calling me a racist? So to say to people, we live in a system that unfairly disadvantages people and advantages some other people, people might say, oh yeah, I can see that. But if you were to say, we live in a racist system, people would, oh, come on now, come on, you're doing well. What are you talking about? And it's particularly levelled against psychiatry because of those obvious disparities in psychiatry with people from minoritized backgrounds, minoritized ethnic backgrounds, being more likely to be sectioned. However, in obst and gynae, obstetrics and gynecology, we know that if you are from a South Asian background or if you are black, you are 2 to 4 times more likely to die in childbirth. And that's taking into everything else into account, your social background, etc. So, for example, women from South Asian backgrounds who are Indian origin, who are actually pretty wealthy, generally as wealthy as white British people, live in, you know, affluent areas, they're still more likely to die in childbirth. And their children are still more likely to have more neonatal problems. And so then you have to ask yourself what's going on there. But no one, I've not heard anyone say obs and gynae is institutionally racist.
Wow.
And so it's difficult for us as psychiatrists to, because when we hear that word racism, as psychiatrists we think, oh, I'm not racist.
Right,
you know,
right.
And because there's still that generally prevailing idea that it's very much an individualized thing. And I've even had very senior professors in this area, this is sociology background, and who said to me, yeah, but it's you lot, you psychiatrists who are the problem. And I said, no, all the evidence says that actually it's not, the problem doesn't start with us, the problem starts, you know, much further down the line. But it's very hard. I mean, you've described really nicely, actually, how as psychiatrists, we need to think of ourselves as being in a system. And we have to accept that the problem starts some way down the line. Right. And then, so the question for me, particularly in my role going forward, is how do we, as mental health professionals, we can do our bit, but how do we also impact on those other factors?
Right.
You know, how do we use the influence of the college to make sure that people understand about social determinants, make sure that people understand about the impact of racism, make sure that we train our psychiatrists so that they understand about the impact of racism, systemic racism, structural racism, so they understand that this isn't about them as individuals.
Right.
And also understanding, you know, psychiatry is so much reflection. We reflect all the time. And the things that we reflect on usually are our interactions with our individual patients. And sometimes there'll be, often there's stuff around the power differential, but it's not usually along racial lines. And we need to start introducing that into our training, actually. And that's going to be uncomfortable for some people, because it will then have to be and it's not just going to be, it's not about a white-black thing, because it will be for everybody. And it will be about what do you, as a psychiatrist, whatever your background is, see when you look at your patient who is black or brown or white. What value do they have, as you described it? And, you know, what value do you assign to them in the hierarchy?
Right.
Because that is really important. And how does that operate in terms of the power structures within the room?
And also just the power to acknowledge that racism exists. If you have a patient who knows very well their whole life has been negatively impacted by racism existing, and you're a person who has been in racism denial, you know, that you don't want to say the word, or, you know, then how can you care for that person? How can you ignore a whole huge part of their lives. So I used to think, not with regard to psychiatry, but I used to think when physicians, any specialty, are trying to make, are meeting a new patient for the first time, they should speak for 2 or 3 minutes just to identify the things they have in common, first of all, because if you speak to anybody on the bus or a plane or a train or on the tube, you will have something in common with them. But also, especially for a person of color, if you acknowledge that racism exists, oh my God, you've just acknowledged a huge part of their experience that otherwise went unspoken and therefore kind of negated, like it's not pertinent. So I think all psychiatrists, to all patients, should acknowledge that we live in a society, in a racist society. And if you're then talking about things that happen within the workplace, certainly if you're in a racist society, some of the things that are allowed to happen between staff members or between staff and patients, the individual interactions are condoned by workplace norms or not looking or that kind of thing, or not believing. And so institutions are created by individuals, and individuals' actions are condoned by institutions. So even though when we talk about structural racism, we talk about, well, I talk about personally mediated racism. I don't talk about interpersonal racism, first of all. He said, personally mediated racism, that's quite a tongue twister. Why are you saying personally mediated? How can you get that out of your mouth, right? But that's because I understand racism as a system, and that's the system mediated through people. So I'm still not putting the racism in the people.
Yeah.
And so we have to understand the relationship between personally mediated racism and the structural or institutionalized racism. And in fact, my Gartner's Tale allegory, which I could sort of just do like a very tiny précis of, talks about 3 levels of racism and helps us understand. So here's the setup for the Gartner's Tale. And oh my God, are we finished in 7 minutes?
Carry on.
Okay. So, no, because I want to share this little story that's up there that you haven't seen. But here's the Gartner's Tale. This is my oldest allegory, very well known now in U.S. public health and in U.S. medicine, published in 2000, 23 years ago. So this is how old this is. And you can find it. It's a 4-page paper, 2 pages front and back. Levels of racism, a Gartner's Tale. I'm trying to describe structural or institutionalized racism, which I define as the system, the structures, policies, practices, norms, and values that taken together result in differential access to the goods, services, and opportunities of society by race. And structural racism is why we even see an association between social class and race in our societies. Structural racism can show up through acts of doing, as well as acts of not doing, and very often shows up as lack of action in the face of need. So we'll put that's structural or institutionalized racism. The second level, personally mediated racism, which some people describe as interpersonal racism. I'm sorry I talked to them and you too. Is it all right for me to do this? Okay. I am talking to you too?
Yeah.
Okay. But yeah, there are more of them. I know, they'll come and get me. No. So the personally mediated racism is differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. That's what most people think of when they hear the word racism. Somebody did something to somebody. The prejudice, and then which is the different idea, the discrimination, the different action. It has many, many impacts, especially through medical interactions. Especially when a physician doesn't give a patient the full range of treatment options. Because the physician figures that patient wouldn't understand, couldn't afford, wouldn't comply, whatever they think, right? That's the subtle way of doing it. Or the blatant way is sectioning them, or or sterilization abuse in the US had many, many different iterations in our nation's history. Yeah. The third level of racism, internalized. Differential, like for people who have been structurally disadvantaged, it shows up as acceptance of negative messages about our own abilities and intrinsic worth. For people who have been structurally advantaged, internalized racism shows up as a sense of entitlement, which then requires racism denial. Because if you feel entitled, there can be no unfair system going on. That is one of the roots of racism denial. So then here's the story. Based on my own real life, my husband and I had been married for a year. We moved from up north to Baltimore, Maryland, because I was going to finish my PhD at Hopkins, and we bought our first freestanding house. Cute little house, big wraparound porch with flower boxes all on the porch. It was fall when we moved there, so it wasn't time to plant. So my husband, he loves to garden, but he held himself back. And then when spring came, finally he ran out with our marigold seeds, going to decorate our cute little house, you know, plant all the planters. But he came right back in and he said, Camara, there's dirt in some of these boxes, but some of the boxes are empty. So I need to go down to the gardening store. So he does. He goes down to the gardening store and he comes back hauling big old bags of potting soil, right? So we fill up the empty boxes. Then we take equal numbers of our marigold seed and put them in all the boxes, and we water all of the boxes equally. And by this time, because I am not the gardener in the family, by this time I was exhausted, right? So I figured I'm just going to sit back and be delighted. So it took me 3 weeks, but 3 weeks later, as I'm walking out of my front door, as I did every day, but as I walk out, I finally pay attention to these flower boxes on the porch. And what I saw made me literally stop in my tracks. Because what I saw made me believe that we had planted completely different species in some boxes versus others, because some of the boxes were full of plants, and they were tall, vigorous-looking plants. But other boxes just had a few plants in them, and they were kind of scrawny and scraggly looking. And then I realized what had happened. That potting soil that my husband had bought turned out to be rich, fertile soil. So all the seed planted in the rich, fertile soil had sprouted. Strong seed, tall and vigorous, but even the weak seed made it halfway up. But that old soil that we had found there turned out to be poor, rocky soil. So the weak seed planted in the poor, rocky soil just died, and even the strong seed in the poor, rocky soil had to struggle to a middling height. And so some of you guys are nodding because you're gardeners, right? So you figure, you know, you've seen this with your own real eyes, the importance of the soil, the importance of the environment. Now I'm going to take that image that we can see together, and I'm going to make it a story about racism by introducing a gardener. So now we have a gardener who has two flower boxes, one which she knows to have rich, fertile soil, one which she knows to have poor, rocky soil. And she has seed for the same kind of flowers, except some of the seed is going to produce pink blossoms, and some of the seed is going to produce red blossoms, and the gardener prefers red over pink. So what does she do? She takes the red seed, puts it in the rich, fertile soil, pink seed in the poor, rocky soil. 3 weeks later, in her flower boxes, she sees what I saw in mine. In that rich, fertile soil, all of the red seed sprouts. Strong red seed grows tall and vigorous. Even the weak red seed makes it halfway up. In that poor, rocky soil, the weak pink seed dies, and the strong pink seed has a struggle just to make it to a middling height. And then in those two flower boxes, those flowers go to seed. And the next year, the same thing happens. And then those flowers go to seed. And year after year after year after year, the same thing happens, until finally, about 10 years later, gardener's looking at her flower boxes, and she says, you know, I was right to prefer red over pink. So we're going to interrupt that story to say the first part of this story is how structural or institutionalized racism works, where you had the initial historical injustice of the separation of the seed into the two types of soil, contemporary structural factors of the flower boxes keeping the soil separate, and inaction in the face of need perpetuating this inequity. But let's pick the story back up and say, well, where is personally mediated racism in the garden? Well, the gardener's looking at her red flowers, and she says, oh, those red flowers are so beautiful. And then she looks at the pink flowers, and she says, oh, those pink flowers sure are scrawny and scraggly. So she plucks off the pink blossoms before they can even go to seed. Or maybe she notices that a pink seed has blown into the rich, fertile soil, so she plucks it out before it can establish itself, which is some of the anti-affirmative action stuff that has gone on in my country. I don't know what's happening over here. And where would internalized racism be in the garden? Well, the red flowers are just living their lives, enjoying being red, many of them not acknowledging or perhaps even understanding that they're benefiting from enriched soil. The pink flowers are looking over at red, thinking red is mighty fine, and wishing with all their hearts that they too could be red. And here come the bees, minding their own business, collecting nectar, pollinating, as they do. So here comes a bee, bzzz, into one of the pink flowers, and then bzzz, to another pink flower, and bzzz, to this pink flower, and this flower's like, get away from me, bee, don't bring me any of that pink pollen, I prefer the red, because the pink flower has internalized that red is better than pink. So now the question arises, what do we do to set things right in this garden? Well, we could start by addressing the internalized racism. So we can go over to the pink flowers and we can say, pink is beautiful, power to the pink. And that is a very important intervention, not making light of that. But if that is all we do, it's not going to change the situation in which those pink flowers find themselves. So you might say, okay, well, let's address the personally mediated racism. Let's have a conversation with the gardener. Or better yet, let's have a workplace multicultural workshop for the gardener, which is all good. So we have our workshop. And in the workshop, we say, dear gardener, would you please stop plucking those pink flowers? And maybe she will, and maybe she won't. But even if she does, it's still not going to change the situation in which the pink flowers find themselves. If we really want to set things right in this garden, we must address the structural racism, which means we have to either break down the boxes and mix up the soil, or if you want to keep separate boxes, that's all right-ish too, although it makes it easier if you have that same gardener. It makes it easier for that same gardener to keep segregating resources going forward, which would mean that at least in the meantime, what you need to do is enrich that poor rocky soil until it is as rich as the rich fertile soil. And when you do that, the pink flowers will flourish. They'll be looking beautiful, grand, and glorious, so that in that intervention on the structural racism, you may even address the internalized racism. Pink won't be over looking at red, thinking red is better, or wanting to be red, because they'll see that they're equally beautiful. And in the intervention on the structural racism, you may also address the personally mediated racism. So internalized is the one you would address. If I spoke wrong, anyway, I hope I didn't, but I may have. Okay. But you may even address the personally mediated racism. Now, the original gardener may have to go to her grave preferring red over pink, but her children, who grow up and see the flowers equally beautiful, will be less likely to have that kind of attitude. So this story has been to illustrate these three levels of racism: institutionalized or structural, that's one; personally mediated and internalized, and to strongly suggest that if we want to set things right in the garden, we must at least address the structural racism. Good to address all the levels at the same time, but at least address the structural, and when we do, the other levels may take care of themselves. But I just want to say three more things about this. First of all, who is the gardener, right? Because after all, and sometimes if I use slides with it, I say, after all, I painted the gardener red. That's why she prefers red over pink. Well, the gardener is the one that I have given the power to decide, the power to act, control of resources, which are actually the elements of self-determination. So who is the gardener in our context? Well, government is always a huge part of the gardener. Media, it's a huge part of the gardener. Your trust and, corporations and NHS, the college, they're different. To the extent that you have self-determination, communities, to the extent that they can wrest self-determination, can be part of the gardener. But whoever the gardener is, it is dangerous when the gardener is allied with one group. I painted her red. That's why she prefers red over pink. And it's dangerous when she is not concerned with equity, when she can look at her flower boxes and think that her garden is beautiful, thank you, because she's not even counting the pink flowers as part of her garden. So then the question arises, what do we do about the gardener? Do we make the gardener striped or polka dotted or fuchsia? Do the pink flowers have to grow or recruit their own gardener? Lots of questions that can come out of it. The last two things I'll say here, and then you guys have to wrap up or whatever you have to do. But first, I was once asked, like, Dr. Jones. I was once asked, why should the red flowers share their soil? When I heard that question, I loved that question because it showed me the power of this story to start conversations about racism that might be otherwise difficult if we were talking about racism between you and me. My answer to that question, why should the red flowers share their soil, is that actually that soil doesn't belong to the red flowers. It belongs to the whole garden. Here's a second question. What if, and if I had put some slides up, I say, what if we're not looking at the original gardener here? What if we're looking at the gardener's great-great-great-great-great-great-grandchild? Here we are. And the great-great-great-great-grandchild has always seen the flowers looking like that, may not even think there is a problem to be solved. So 3 things we need to do about that. First, we need to make the differences in the height and vigor of the pink and red flowers a problem requiring urgent solution. We need to put it on our urgent action agenda. There might be a thing you have to do before that because so many people have, at least in the US, have been seduced into this idea of racist biology it's like, why are you putting that on the agenda? But in my story and in life, I said, these are seed for the same kinds of flowers. And we are. So part of it might be first addressing that biological deterministic idea of race, if you have that heavily within your profession or within medicine here. But you can already put it on the agenda and let people ask you why, and then you would just like, get out of my way, But anyway, so first you had to put it on the active agenda. Then, so now it's on your action agenda. What are you going to do? Well, you have to make the flower boxes transparent. We need to be talking about the differences in the quality of the soil so that we can address those differences in the quality of the soil. But here's the very important third thing. As we make those flower boxes transparent, we need to make sure that everybody understands that the pink seed did not just go launch themselves into that poor rocky soil. So we must talk about history, right? How did it get like that? And we must also talk about the gardener's initial and ongoing preference for red over pink, which actually set up and is perpetuating this situation, which some people would call that cultural racism. In the US context, I call that white supremacist ideology. We must address that directly. That is the underlying value system in all of this. We must address that directly because if we do not, even if we were able to compel that red gardener today to enrich the poor rocky soil today until it was as rich as the rich fertile soil today, if she continues to prefer red over pink, she will continue to privilege red over pink going forward. So for many years, my gardener's tale was just about the structural racism, the soil and the flower boxes, until maybe about 5 years ago in the telling. Like in a group like this, I was like, oh my God, right? We must address both things. When I defined racism as a system of doing two things, structuring opportunity and assigning value, we must address both if we're going to set things right in this society. So,
Thank you. I think we're going to go to questions there, but first of all, okay, so first of all, have we got any questions from the room?
Sorry, I'm not a psychiatrist. I just thought maybe
Hi,
the
Eva.
psychiatrist should ask questions first.
no, please,
No,
you have the mic.
It doesn't work like that,
Oh my gosh. Oh my gosh.
I was just saying hi.
no. Hi, Ethan, go ahead.
My name's Evie.
Why don't you stand up, please, so everybody can see you easily?
All right. My name's Evie Mensah. I'm actually an ophthalmologist. And I think I'm girl fanning you, actually, because I think this is the second time I've actually seen you speak. I saw you speak at KCL on the 16th of January. And I've just been appointed as the first EDI chair to the Royal College of Ophthalmologists.
Oh.
Thank you. And I was interested to come here all the way from northwest London, which is where I've driven today. It's taken me over an hour. Because you talk about collective action, and I did ask you this question before. You talk about collective action, and you talk about how it's powerful, it propels you, it inspires you, it informs you, and 100% I absolutely agree with you. But I asked you before that how do you incentivize others to be part of that collective action? Because what happens in the NHS, and we see it happening day in, day out, and we have the data already with our NHS England reports from the NHS Staff Survey, we've got our Workforce Race Equality Standard reports, and we've got our Medical Workforce Race Equality Standard reports that completely confirms that systemic racism exists in the NHS. So we're not talking about psychiatry or the Royal College of Ophthalmologists or OBS and Gynae, it's throughout the NHS. But what we have within the NHS is that we do not have anti-racist leaders. And we don't have safe spaces to raise concerns. Because when people raise concerns, and I know you say that racism is a system, there are people in the system that perpetuate the system of structural racism.
That's right.
There is no safety. and it's causing a lot of psychological and physical damage to the NHS workforce. So my question is that first, how do you organize others to understand the power of collective action? And then the second thing is that how do people call out or call in systemic racism that they may be experiencing?
Yes, well, isn't that the question?
Yeah, in fact, actually, just to say that there's a very similar question here from online, and the question has been actually about the situations that the person's been in. They've encountered racist views from staff about patients, or from patients about staff, and how do you actually practically tackle that? So it's very similar point.
Yes. I have been trying to equip people with these stories so that they can start little small discussion groups and get more and more people naming racism. So what I have, and I don't remember if I told you before, to just like take the Gartner's Tale allegory, the 4-page paper, 2 pages front and back, and say, okay, we're going to have a team meeting or a lunch or thing or whatever, whatever training or whatever, and have people discuss that story, but not because you're trying to judge people on what they say about the story, but you're trying to hear how they talk about these issues, and to identify allies, unexpected allies sometimes, or compatriots. I don't like ally, because when I said ally, people probably already thought about white people, right? And I'm not talking about that, And all of us are affected by racism. Racism is sapping the strength of the whole society. But to identify other people who would be willing to stand with you and speak up about racism with you. And so sometimes you know who those people are, and sometimes you don't. So a good way is to take a paper and just hear how people talk about it. Then you identify 2 or 3 people out of that, and you go up to them afterward and you say, well, have you noticed the same thing that's going on here? And then you guys start organizing with each other. So don't assume that somebody is going to want to join with you, especially even if you know that they filed a complaint or whatever. I mean, people feel very vulnerable. It's a very hard thing, right? So it's a way of identifying readiness without saying that that's what you're trying to do. Just say, oh, I heard this speaker, this sister from America, right? And here's a paper. Or a really easy thing. So I have a TEDx Emory, so a mini TED from 2014 that has 4 of my allegories. So it has a quick version of the Gartner's Tale, a quick version of this one that I didn't get to tell, Dual Reality, but this is the one that I've been telling a lot here in this country, and I find that it's really good. So if we have maybe 5 minutes at the end or so, I might try to tell that. And 2 other allegories. So that's a good thing. But what you're really trying to do, you're not trying to push anybody beyond readiness, but you're trying to find people who are ready. So maybe, does anybody else in the room have other ideas to answer her question? Yeah. Maybe take the turn afterward. No. Okay.
I've got something in common with a lady. I'm called Evie as well. But other than that, I'm a psychiatrist, consultant psychiatrist in child and adolescent mental health. I'm glad you mentioned the NHS, because I think this was the common denominator in your both stories. You mentioned obs and gynae and psychiatry, and how come that both seem to be underlying racist. Well, the underlying common denominator is the NHS. And don't get me wrong, I don't want to be negative about the NHS. It has fed me for 15 years. But I know it very well. And I know that there can be pockets in the NHS, because NHS is an institution, and because it's getting bigger and bigger, we know that big institutions do tend to somehow breed racism in one way or another. So back to your question, what do we do about that? I've been a doctor for many years, and I know that we do audit all the time. I know that we do job plans all the time. I would want to see once in an interview with a manager, or indeed a doctor, becoming as part of their job plan or their agenda for the next couple of years or 5 years, how have they tackled racism within their team, within their department? And I want to see SMART. I want to see goals that are measurable, in this end, and they will not get promoted unless they show evidence that they have tackled racism, whether based on a complaint, whether based on anything. I want to see action, but in numbers. And we know that NHS can do that very well. Okay?
Yes.
So that is a proposal on my end. And can I also say something else? I agree, we psychiatrists are very good at reflecting. And I think those of us who have done psychotherapy as well are maybe slightly even better. I don't want to sound racist in that respect, though. What I was going to say is, do we ever reflect, though, on those nuanced things as, I've sectioned this patient today, have I informed them of their rights or not? Have I informed them of their options of treatment? The treatment I've just prescribed today, have I offered them the option of not to receive treatment and what that would mean? How often do we do that kind of reflecting on a day-to-day basis? How did I do my job today? How much freedom and option did I offer to patients? Could I maybe have discriminated against someone? And most crucially, could I be a victim of discrimination from time to time within my job environment? Because this will make me more sensitive to recognizing that and indeed growing within that environment. If we can recognize things on our skin, we can then recognize those on others, is my view. And that's how I would end it.
Thank you. Thank you.
Can I just say, actually, that Evie, you'll be pleased to know that as part of this guidance, we have actually said that within appraisals and supervision, there should be an expectation that people are addressing race equity issues. And also I'd say, I don't think it is just the NHS, actually. I think it's just that the NHS is just easier to see because of all the audits and everything else that we do. But it looks like, you know, racism exists everywhere, even in non-NHS services, charitable services, third sector services, private, independent services as well. And finally, I think about my practice, I think that actually lots of people do reflect. I think, as I said before, I think the issue is that I'm not sure that when the reflection's done, there is a thinking about racism because people think about racism as being like individual stuff. They don't think about, is anything within this, because I'm working within the system, is what's the disadvantage that this person has already been impacted by, and how might I be contributing to that?
Just a quick counterpoint, exactly. But if we think more in terms of abuse of power as opposed to racism, I think if we become more sensitive around possible abuses of power from small to big ones on day-to-day basis, it will then gradually should become easier to tackle racism. You can't just make a leap to tackling racism. It has to be from small steps, like, are there any small abuses of power on a day-to-day basis, from non-informing patients to actually omitting actions to doing things that are not really possible. So, because we can't really be, it was in the news the other day, we can't be at the receiving end. So many emergency ambulance staff are at the receiving end of abuse. So I wonder whether this is now the abuse of power bouncing back to some extent to us, because we're just not doing things in ways that feel fair and just. That's a concern of mine. It can't just be that the NHS is at the receiving end of so much abuse. Could we be not missing something here that sort of is bouncing back? Question mark.
Okay.
Thank you.
All right.
Thank you. Amrit Satchar, I'm a liaison psychiatrist in West London. Absolutely loved your talk, as I always have. And I love the stuff about collectivism, and I love the stuff about having the hope, about not needing to see the fruition of our work. And I think as psychiatrists, we're good at that. We quite often have interventions where we see where we don't see the outcome of what we've done. So we should be kind of used to that. My question is, I hope you can help me with some of the conversations that I have with people about, yes, that's all well and good, but is this the biggest problem that we are facing at the moment? What about the fact that our planet is going to hell in a basket. And what are your thoughts on people who are trying to set up a league table of issues and justice? And I guess part of that, but in a smaller way, I'm hearing so much pushback about what about poor white boys? Right. I'd just be interested. I know I feel like I haven't quite got that down.
So when I defined racism, so I'm going to say it in a few things. When I defined racism as a system of structuring opportunity and assigning value based on race that unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society through the waste of human resources, that definition of racism can be generalized to be a definition of any system of structured inequity. So what is sexism? That's a system of structuring opportunity and assigning value based on gender. So it's based on that unfairly disadvantages some, unfairly advantages others, saps the strength of the whole society. And I do recognize that there are many axes of inequity operating in our society today, intersecting in communities, intersecting in individuals, and that all of these are at least risk markers for how opportunity is structured and values assigned. A smaller group also risk factors in the progression to bad health and other things. And so when people hear me acknowledge that, they say, well, okay, I got you. So then why are you so focused on race as the axis of inequity and racism as a system of structured inequity? And it is because racism is foundational in our nation's histories and wealth, and yet so many people are in such staunch denial of the continued existence or pertinence of racism. So when you have that combination, at least people acknowledge the other issues, right? And they also are not as foundational in the history. This is the big blind spot. Racism is foundational in this nation's history, as in my nation's history, and yet there's so much denial. We must all be actively anti-racism, and I don't even say anti-racist. I say anti-racism because I don't want the confusion. Ooh, is she talking about me when I say anti-racist? No, I'm not talking about you. You might be part of the problem. Yeah, I mean, you just sort of raised your hand and said you might be, by saying, oh, is she talking about me? But no, I'm not. I'm talking about a system, right? But so we have to at least all be actively anti-racism, even as we also engage in as many of the other struggles as we can. And to the extent that we're able to dismantle racism, the other struggles will benefit as well. That is going to be true probably at least for the next 100 years, right? Unless we go faster than I think is possible, but we might. So it's the combination of the foundational nature with the denial. If we do not lift it up and hold it as central in our struggles, then we will never, ever address it. So, I also wanted to say something to you about, and Lade, when we're talking about holding people accountable, I am wondering, is it possible to review individual physician practices or group practices over, say, 2 months or 6 months or whatever, and then feed those data? Has something differential been done by patient race or by whatever you want, in terms of prescribing practices or whatever, and then feed that back at the individual level for improvement, for self-improvement? Is that done?
So it's not done. One of the things that has been mooted is the idea of, for any trust, looking at section rates by doctor. And some people don't detain people, but there are some that do and have to do it quite frequently, and seeing if there are any differences. So that, it would be that you see for yourself when you're benchmarked against everybody else. That's interesting. All the people I've sectioned happen to be black. Now, if all your catchment area is full of black people, then fine. But if it isn't, then and there's disproportionate rates, then what does that mean? So we talked about this a few years ago, and in fact, when we were doing the Mental Health Act review, and that was one of the suggestions that should be done. In fact, at that time, certain people said, "Oh, can't do that." Now that was a different era, and that's something that
people will still say that because people don't want to be held accountable for the thing, and they don't want to discover things about themselves. Yeah. They're afraid of the mirror. They're afraid of the mirror because at some level, we all acknowledge we live in a racist society, and maybe it has affected us, Nobody is born racist. I try not to say that word, but nobody is born that way. But we grow up in this system that gives, that differentially structures opportunity for those of us. And then if we see certain things, then we think that that's innate in the people. I'm going to talk about the 7 values targets for anti-racism action. But that this system, yeah, let me get to that. So, racism denial, big problem. There are 4 roots of racism denial, which are a subset of 7 what I call societal or cultural barriers to achieving health equity. I'm going to name them, and then I'm going to go a little detail on some. The roots of racism denial are our narrow focus on the individual. I talked about that a little bit. Our ahistorical stance, our endorsement of the myth of meritocracy, that if you work hard, you will make it. Now, I give you that most people who have made it have worked hard. I bet all of you guys in this room have worked hard. I say most people who've made it, not all, because we have the monarchy and the Trumps, and we have, you know, people like that. But most people.
Remember, this is the Royal College of Psychiatrists.
Woo, sorry. Okay, anyway. And you're very grateful, right? Anyway, but even though most people who have made it have worked hard, there are many, 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 many other people working just as hard or harder who will never make it because of an uneven playing field, which has been structured and is being perpetuated by racism, sexism, heterosexism, all of these systems of structured inequity. And when we deny the existence or pertinence of these systems, when we deny racism, either by saying, I don't think racism exists, or by never saying the word racism in the context of widespread and deeply held racism denial, then we are complicit with that racism denial. People, when they deny these systems, blame those who haven't made it for being lazy or stupid. So then when we start seeing, we grow up and then we see these differences in terms of who has what and all, and then we start interpreting that as reflecting individual worth. So anyway, I digress. So the narrow focus on the individual, which makes systems and structures invisible or seemingly irrelevant. Ahistorical stance, act as if the present were disconnected from the past, and as if the current distribution of advantage and disadvantage were happenstance. Myth of meritocracy. The 4th one, that is the root of racism denial, is white supremacist ideology. And I say that not as a lightning rod term, not to have somebody's mind go, did she really say that, right? But as a description of a false idea. The false idea that there is a hierarchy of human valuation by race. There is not. And the falser notion that, yes, there's a hierarchy, and that would put white people at the top as the ideal or the norm. But many people have that idea. That is actually, I think, the fundamental impetus for what's happened in the United States, settler colonialism with a lot of the imperialism, this kind of white is the best type of thing. So a lot of English-speaking and other European and colonized countries, this white supremacist ideology is very pertinent. And in my country, well, in all of these countries, it gives people who are living as white a sense of entitlement. It has resulted in the dehumanization, devaluation and dehumanization of people of color. And in the US, fear at what is described as the browning of America, which has led to our very explosive political divide today. Those are the 4 roots of racism denial. The other 3 that are also cultural factors, that are barriers to achieving health equity, are our myth of a zero-sum game. If you gain, I lose. That puts us in competition with one another. It masks the cost of inequity to all of us, and it makes it harder to grow the pie. Our limited future orientation, you talked about the planet, and, so the parts of the future that all of us can touch today that will hopefully survive us are the children and the planet. I will say that in the US, we have a disregard for the children and a usurious relationship with the planet. And then finally, the last one is the myth of American exceptionalism, which I understand you have a myth of British exceptionalism and probably lots of different things, which makes, like as if we are so unique, so ordained by God, so special, that there's not even something that we can learn from other countries, and that we're entitled to all of this wealth and other stuff that we have. So those things are operating against us. Those are the cultural things. When I have been asked, should I be quiet now? Can I say one more thing?
Yeah, I mean, I have to say, I have let things slide
Oh,
big time.
okay,
We are
okay.
50
So I
winning
won't say
50
another
minutes.
word. I won't say another word.
Well, no, final word to you before I hand over to Raj for our closing remarks. So is there anything final you want to say?
Anything final I want to say? I want to invite everyone into being actively anti-racism. That's it. Which means name racism, ask how is racism operating here. Oh, I didn't tell you how to do that.
Next time.
Next time. And then organize and strategize to act. It's really at looking at the elements of decision-making. Structures, who, what, when, and where of decision-making. Policies, the written how. Practices and norms, the unwritten how. Values, the why. Don't think of it as policies, structures. Think of it as elements of decision-making. Most important, who's at the table and who's not.
Thank you. So I'm just going to hand over to Raj Mohan, who is my counterpart. He's a joint presidential lead for race and equality at the college, and he's going to make some closing remarks. Just going to summarise everything that Camara just said.
How can I summarize something that's presented so succinctly and clearly? Can I just say, it's been such an amazing experience listening to you. You have explained things in such clear and simple terms. You wouldn't use the word eye-opening lightly, but this is the way the talk was today. And thank you so much for bringing it to us here at the Royal College, which is the seat of the structure. Can I just ask everyone to give another big hand to Professor Camara Jones? It's incredibly timely that today's the day we do the soft launch of the Tackling Racism guidance that we're producing. So hopefully some of the ideas are already in the implementation of this, and we'll be able to take it forward as a group of people. So I want to also thank Dr. Lade Smith, our next president. Being in this conversation, I've never seen Lade so quiet. But this is an event. It's not for me to actually stand here and thank anyone. Actually, it's the Women's Mental Health SIG who have organized this. So big thank you to Stella and Raka, because this event wouldn't have happened. So I'm actually saying thank you to everyone on your behalf today. So as part of this, we have a few people to thank. And Lade, you've already thanked Adrian James, who kind of set the ball in motion. Ruth, you are leading the work. Paul, for all your incredible support and guidance through the work. And to our amazing comms team, Corinne, thank you for leading on this. The whole idea is that it's not enough for us to produce guidance and put it out there. You actually need to take it to people. You actually need to make sure that people understand what this is for, buy it, absorb it, and actually start doing it. But those kind of conversations need to happen amongst us. So the college is a big organization. We have 20,000 members. So we got a significant proportion of our members enthused about it, and they're taking the work back to their hospitals, to their colleagues, and they're discussing, challenging, questioning, and trying things out. We do have a chance. I think we mentioned something about accountability. So accountability is going to be a core part of the work that we do. People have to produce results. That is why they're in leadership roles. But it's not just the leaders. Everyone needs to look at themselves, their behaviors. If you look at the workforce, it's the majority or significant proportion of our workforce is non-white, actually. So you do have to think racism isn't just a black and white thing. It is about structures and systems, and we need to dismantle them one bit at a time. So I could say much more, but hashtag is Act Against Racism. Watch out for it, 26th of June. And I believe there are some drinks and nibbles. I hope you'll all stay, talk, discuss, mingle, connect. And thank you again for coming today, for being our brilliant audience.
fantastic.